Hi, everyone. Today we are going to talk about some of the reasons why you may transfer from a home birth or birth center birth to the hospital. One of the common things that I see, like partners often being afraid of when it comes to choosing an out of hospital birth, is like, what if something happens all of a sudden and there's an emergency and we need to get to the hospital? Most of the time in emergent situations, there is enough time to get to the hospital. Anesthesiologists and obstetricians aren't just sitting around the hospital all the time waiting for someone to need them. They're on call. So that means that if you call the hospital and you say, we have a cord prolapse, for example, where the baby's cord slips in front of their head. So in that situation, the midwife team will call the hospital and say, we have a transfer coming in who needs a cesarean for this reason. And then the hospital will call the obstetrician and they'll call the anesthesiologist. And now those people have to get to the hospital. If you were in the hospital, it is also possible that the anesthesiologist is not there. And so if something were to happen, they would need to set the room up and call the anesthesiologist in. So, a lot of people think that if you're in the hospital, you're safest because if an emergency were to happen, you have easy access to emergency care. But the truth is that many interventions in the hospital lead to the need for emergent care. When the person who is giving birth receives Pitocin or an epidural, or they're pushing on their back, these interventions can all lead to the baby struggling with their heart tones. But in a normal physiologic birth out of the hospital, where the person who's giving birth is supported in birthing in upright positions, they're birthing in the water, they aren't using any medications during birth, none of the risks or adverse side effects to the medications are now present with that person. And so this really decreases the risk of anything emergent happening. So when there is a good system in place, and this is why it's so important for these systems to be there, for providers to be able to collaborate with each other and for midwives to be respected by obstetricians, for obstetricians to be respected by midwives, and for there to be a transfer policy, a transfer cooperation in place in the community to help the out of hospital birthing families be able to transition to the hospital easily without any fuss or hassle or difficulty. And there are some communities that are working really hard to connect the out of hospital midwives and providers with the obstetricians and midwives who work in the hospital to be able to have sort of like a cooperation and a pathway to help families get the care that they need faster. So, if you have any questions about how transfers look, it's good to talk to your provider about that so you have a good understanding around what that looks like. And also, different hospitals have different ways of doing things. And so, you may feel better going to one hospital instead of another one if they're both kind of a similar distance to you. There are two different forms of transfer. There's emergent transfer and there's non-emergent transfer. So emergent transfer happens when something urgent occurs where the need to get the mom and the baby to the hospital suddenly arises. And in most circumstances, with an urgent or emergent transfer, calling 911 and having EMS come to your home or come to the birth center and pick up the mother or the mother and the baby if the baby has been born and take them to the hospital is often best. The thing to be aware of with EMS is that sometimes in some communities, EMS are not as skilled or as practiced when it comes to supporting the baby after the baby is born, and they may not have the same kind of tools that a midwife would have. So, if EMS were to arrive for the baby and the midwife is taking care of the baby, it's often better for the midwife to continue caring for the baby as the transfer happens because the midwife is the expert around what's going on and EMS is not. So, going back to having mutual respect and cooperation in the community with these transfers, if the EMS team in your community are trained and they respect midwives and they collaborate well with midwives, they'll be able to go and see that there's a midwife there. And if they know that midwife, they have a relationship with that midwife, they're aware that that midwife is licensed, then they'll be able to just support and assist that midwife doing what she's doing and just help her get the baby to the hospital. Most of the time, if a licensed midwife is present at the out of hospital birth, they are the ones who should be in charge, taking care of the mother and baby, and EMS is really just there to drive. When EMS arrives, they probably want to know what the mother's last vitals were and the baby's last vitals were. And if you are going to transport a baby through the ambulance, it's important to be aware of a couple different things. One is that the ambulance can be cold, so having blankets for the baby is really important. It is really important that your baby does not lose heat. So putting a baby in a cold ambulance could be more harmful for them. So if possible, having the person who birthed the baby or the other parent to be skin to skin with the baby with warm blankets during transfer is probably best. If there were to be an accident, obviously the baby wouldn't be as safe because they're not in a car seat. But putting a baby who needs respiratory support, and that's why you're going to the hospital to give them respiratory support, putting that baby in a car seat may restrict their airway and make that issue worse. So in that circumstance, it may be a better choice to be skin to skin with the baby and hold them in a way that allows their airway to be open. And the baby might need to continue to receive breathing support as the transfer is happening. Okay, so let's talk about some other emergent reasons for transport. One is the presence of fetal heart tone concerns. So your baby's heart rate ranges from 110 to 160 throughout labor. When you have a contraction, the baby's heart rate can dip slightly. It's still within that range of normal, and that's okay. It's just important that your baby's heart rate recovers after the contraction, so the heart rate starts to come back up on its own. So maybe your baby's heart rate is a baseline 140. So most of the time it's around 140. They might move a little bit and have an acceleration and the heart rate can go up. And then they come back down to baseline, which is about 140 for them. So during labor, when you have a contraction, the baby's heart rate may start to dip down a little bit, especially as your baby is getting near the pushing phase. Maybe it will drop down to like 120, and then it will come back up to its normal baseline. It's when baby's heart rate starts to drop below 110 that it can be concerning. Sometimes this means the baby needs to be born faster at home. Other times, it's better for the mother to not push and to instead try to lie in a position that helps support baby in getting as much oxygen as possible, often in their hands and knees as best. And baby may need to be born with a vacuum or forceps assistance or through a cesarean. Another reason for emergent transport is when the cord reaches in front of the baby's head, and this is called a cord prolapse. This can be very dangerous because what it means is that as the baby's head descends through the pelvis, they're putting pressure on the cord, and that ultimately leads to less oxygen that the baby is able to receive. So in most circumstances, this situation would warrant a cesarean, and it's absolutely vital that the mother gets to the hospital as soon as possible. With this situation, midwives are able to put their hands inside of the mother's vagina and push the baby's head off of the cord. They'll have to hold their hand in their vagina throughout the whole drive to the hospital. But as long as the pressure of the baby's head is not on the cord, then the baby will continue to receive oxygen and they will be okay. Another instance where the need for transport emergency were to arise is if there is a lot of bleeding during birth. A little bit of like blood-tinged mucusy stuff is totally normal. That's probably your mucus plug. But bleeding a lot of bright red blood during labor is not normal. This may mean that the placenta is starting to shear away from the uterine wall, which is also called a placental abruption. This can lead to hemorrhage, which is where the mother loses a lot of blood, and that can be life-threatening. And this can also be life-threatening to the baby. Another reason could be that maybe we identify that the baby is breech and you don't want to have a breech vaginal birth, but you would prefer to have a cesarean birth. The mother should also go to the hospital if she suspects that she's in preterm labor, which means that before week 36 or 37, it's important that the mother go to the hospital because the baby's lungs are probably not developed yet. And if the baby were to be born, they would definitely need some assistance with breathing. But if you suspect you're in preterm labor and you go to the hospital, there are different interventions they can use that can sometimes keep labor from happening. And the last is when you see a lot of thick, dark meconium. So when your water breaks, if the water is clear, that means the baby hasn't pooped. If the water has a yellowy or green or dark brown tinge to it, that may mean that the baby has pooped. It used to be thought that seeing meconium when the water breaks is super concerning and is an emergency for everyone. The truth is that there are different colors of meconium and every color can mean something a little bit different. So if you're seeing a lot of dark meconium in the water bag, that probably means that the baby is under stress. When the baby is stressed, they often will poop in utero. But having a little bit of meconium, lighter meconium staining, does not necessarily mean that the baby can't be born at home. And in this gray area, it's important to talk to a provider who is skilled in assessing meconium and also is able to look at other signs that your baby is doing well, such as their movement and their heart rate. And the last that I'll mention today is in the case of a postpartum hemorrhage. And a hemorrhage is defined by losing about 500 milliliter to 1,000 milliliters of blood. And out of hospital midwives are trained in being able to assess blood loss and estimate it, but oftentimes they use chucks and then they weigh the chucks afterwards to be able to know exactly how much blood was lost. In the case of a hemorrhage, there are several different medications that can be used at home. Sometimes, if the mother is not looking like her body is responding well to the medications, then EMS will be called to transfer her to the hospital because she may need more medications or she may need some more higher medical assistance or even a blood transfusion. The need for this is very, very rare. So getting Pitocin injected into probably your arm or your thigh is one way to help the uterus to contract, to deliver the placenta, and to slow bleeding. Pitocin processes through the body quickly, so it's often better if you continue to hemorrhage to have an IV drip with Pitocin, which is something that out-of-hospital midwives can do. But if you aren't sure, it's good to talk to your provider about that and make sure that that is something that they offer. Another medication that can be used is called misoprostol. So when I assisted with hemorrhages, we would take tablets of misoprostol and give them to the mother to keep in her cheek to allow it to dissolve. And during that process, we would also give her some Pitocin. So the Pitocin is causing her uterus to contract immediately to slow bleeding, and the misoprostol takes a little longer to kick in, but it does last longer in her system. Misoprostol can lead to feeling like you have a fever, feeling like nauseous and shaky, so it's not a super fun medication to use, but it can be life-saving. There are other medications that can be used for hemorrhage prevention. Those are just the two that I am used to. When it comes to non-urgent transfers, this means that there is not a medical emergency, but for whatever reason, the person giving birth feels like they want to transfer to the hospital. And so that looks like wanting pain medication support. So maybe you've had a really long labor and you want to use an epidural as a tool to help you to rest. I have seen epidurals be used as excellent tools for women who have really long labors and they're exhausted. And getting the epidural gave them the opportunity to rest and also like to surrender to the contractions, like for their body to soften and relax because they were tensing up so much in the presence of contractions. They were no longer really productive. And another reason is maternal exhaustion. So if you're feeling like dizzy and weak and like really not okay anymore, that may be a reason to transfer to the hospital because maybe you are needing some support. And then there is prolonged labor. So this is when labor lasts a super long time and it gets to the point where maybe not a lot of progression is being made anymore and you're just getting more exhausted and more exhausted. And the last reason that I'll mention today is if an infection were to become present. This is not a reason necessarily to call EMS, but it is a reason to get in the car and go straight to the hospital. Because if you are not feeling well and you have a fever, that means that you may be getting an infection and that can be very dangerous for both you and the baby. So it's really important that you seek out medical care if that were to happen. Know that in out-of-hospital births, all of these things that I just mentioned are super, super rare, but they do happen. And that's why it's important that you feel really confident in yourself and in your choices. You feel safe, you have a team that you feel good about, and you have had these conversations with your support team about what the transfer process will look like, because that way, if a transfer were need to happen, everyone is on the same page and we've already talked about it before. I find that sometimes when women don't want to have the conversations about transport, if a transport were to happen, it could feel really like overwhelming and scary for them because we haven't like kind of mapped out how that's going to be. And so having those conversations beforehand with your team can be super helpful. Know that your body was made to do this and you've got this.